Good morning, everyone, and welcome to the second day of Biopsy. Drs. Rodriguez and I would like to welcome everybody.
Our next speaker is Dr. Maria Antonia Sarnil with the topic Observation in Small Uveal Melanoma in a Spanish Population. Please, Dr. Sarnil.
Well, good morning, Chairman and friends. I'm Dr. Maria Antonia Sarnil. I work in Valladolid, where the arrow is, running one of the 3 national referral centers of intraocular tumors. And I first met Dr. Bournier in the 1990 in Boston when I was doing the fellowship. But the main part of our collaboration and friendship come from '92, where we met in Brussels. Dr. Bournier introduced me to Rui Proença, and we started doing ocular pathology courses and friendship with family, with the daughters, with the sons for more than 20 years now. So thank you very much for introducing me to Rui and this good relationship with Portugal and all these scientific things. Well, as Dr. Singh told us yesterday, patients with smaller choroidal melanomas at the time of treatment have a better survival prognosis than those with large tumors. And one of the few things we can do with the melanoma patients is to do the early detection and treatment in order to prevent metastasis. But there is a controversy around the small melanocytic lesion or melanomas. There is a lack of homogeneous diagnostic criteria and terminology. They can be called small choroidal melanoma, indeterminate choroidal melanocytic lesion, as Dr. Singh named, suspicious nevus, large nevus. But any way we call these lesions, the important thing and the main objective is the early detection of the potential malignant lesions. How can we do that? First of all, if we follow the lesions and they show documented growth, is melanoma and we have to treat it. But indirect signs are these well-known factors predicted for growth that we can use in our clinic daily. In addition, there is no data on natural history of untreated tumors, and there is a lack of randomized prospective trials comparing early with the late treatment. And the main question, is it safe to observe until growth, is still without an answer. We review the survival of, in 2012, of our 480 patients with melanoma. And when we analyze the survival by size, either by COMS or TNM size, we were surprised because we have no metastatic deaths in the group of the small choroidal melanomas. So the purpose of the present study was to assess the tumor growth and survival of patients diagnosed of small choroidal melanoma under observation in our referral intraocular tumors unit. The design was a prospective consecutive non-interventional case series, and the inclusion criteria were patients diagnosed with a small choroidal melanoma with a height of 1 to 3 and basal diameter 5 to 16. And these small choroidal melanomas have to present 1 or 2 risk factors only for observation. If we have 3, we treat the patient, and no extraocular or systemic extension. The follow-up has been every 3 months during the first year, every 6 months up to the 5th year, and yearly afterwards. What happens if in the follow-up we find documented growth? Then we treat the patient with brachytherapy, usually. And if done, we study the risk factors. If we find 3 risk factors, we treat the patients. If we have 1 or 2, we keep the pattern of the observation. All this data has been included in a special the database we have working for more than 20 years on uveal melanomas, and From a total of 642 patients, we have under observation 27% of them. The mean age was 65 years and the mean follow-up almost 6 years. The origin of the patient is all the blue areas you can see is our area of influence receiving patients. And one particular thing in these cases is all the patients are white Spanish. That means we are Caucasians. But I think that Caucasian from Spain or from Portugal are not the same Caucasian than from Finland or from Sweden. We are different in the color of the eyes and other characteristics. Most of the 65% were female, and of course, since these are small lesions, more than 80% we discovered in a routinary examination. Mean basal diameter was 7.16 and mean height 2.1, and most of the color of the eyes are brown or green, having only, as always in our series, 80% of people with blue eyes. What happened with the tumor growth? How many patients with these small melanocytic lesions show documented growth? 9 in total. And from 9, 8 show the growing in the 2-3 years after the follow-up. And all these patients have been treated with brachytherapy. And if we compare our data with the COMS study with similar clinical characteristics, studying 204 eyes, we observe that our proportion of eyes growing in the follow-up is much lower. In the first year, COMS showed 11%, and in our study was 1.7%. And in the fifth year, COMS study showed 31%, and in our study was only 5%. This is a sample of one of the patients who is being followed for many years, a woman asymptomatic, discovering this lesion, juxtapapillary lesion, in 2002, and she has been followed for more than 10 years, and the lesion was in the same way, no showing documented growth or factors predictive of growth. However, this other woman, 50 years old, diagnosed in July 2009 with this lesion showing a little bit of orange pigment and subretinal fluid over the lesion, was followed, and 1 year later, she showed more orange pigment, subretinal fluid, and documented growth in the ophthalmoscopy. So she was treated with brachytherapy and still is preserving some useful vision in the eye. And what about the mortality? The non-specific mortality in this series of patients was, we have a total of 13 deaths, 7.6%, and the survival at 5 years is 88.6%. But analyzing the specific mortality, we have only 1 death due to metastatic disease. That means that our survival proportion at 5 years is 99%, and we have not registered other metastatic disease. It's difficult to compare these results because our numbers are not very high, and the design of the studies is different. But analyzing the 5-year mortality of all of these papers, studying small tumors, we have the lowest mortality in the literature. In conclusion, in our series, small choroidal melanomas under observation with more than 5 years of follow-up show a low rate of tumor growth and low mortality due to metastatic disease. And we keep observing these patients now. Thank you very much, and I would like to show to you, I am looking forward to see the new laboratory, but I would like to show to you what was the first room of the laboratory in 1994. This bunch of people smiling with a lot of dreams, things to do with the laboratory, and all of us visiting Miguel and sending our residents have a dream, the dream of having a society where we can meet, share our worries, our scientific discoveries, and make friends and enjoy, and you make it possible. You are a dreamer, a dream maker, sorry. And that was Biopsy 2010, and I have the privilege and the honor to host the second edition of this society, organizing with Dr. Blanco also. That was great. But I think that we are improving every year, improving the science and improving the friendship, and I would like to thank not only Miguel, but also Nora, who is one of the great supporters of this big scientific family. Thank you very much for your attention.
This girl is? This is the girl that presented yesterday.
It's Julie.
She was 7, 6.
Any question or comment to Dr. Sarnil? Dr. Singh?
Oh yeah, this is an excellent work, and it supports the idea that observation is a good thing to do if we have only 1 or 2 risk factors. So the data of mortality 1%, and say what is the harm in observing? Well, there's the harm. 99% you're going to die from it, and so it's okay to observe in a low risk disease.
Yeah.
What I want to ask from you is that how did you determine the risk factors? Was it on exam, or on autofluorescence, OCT, or a combination?
We perform retinographies when the tumor is accessible, autofluorescence, and OCT to determine the subretinal fluid and the orange pigment.
And in the 9 cases where the tumor grew, was there anything different in those 9 specific cases, or just?
No, I'll try. I have the data of the 9 cases, thinking maybe they have all 2 risk factors and over 2 millimeters height, but they have no a pattern. The 9 cases have, you have very small ones and you have very extensive but short ones. One of them is 2.4 in height, but they don't follow a pattern.
And the last comment, the patient that died of metastasis, was it biopsy-proven metastasis?
No. In Spain, it's very difficult to get the biopsy proven if you are not going into a clinical trial for something. But the patient show only metastasis at the liver, and all suppose that the liver metastasis only in the liver were related with the eye.
Based on ultrasound or CT scan?
Yeah.
But not biopsy?
No.
You know that 10% chances are it could be something else. It could be something else.
Then we have zero the specific mortality.
Yeah. So it's almost 0.
Almost 0.
Because we know that, like case presented yesterday, you can have multiple etiology, patient can have other tumors, and also in CRS, they can come all metastasis with biopsies. And in some cases, it was something else, like adenocarcinoma, like a colon or the basis.
Yeah.
That has come to liver. So not all meds in melanoma patients are necessarily for liver melanoma. And so it's quite possible, maybe to have a proof that it could be that one case may also not be true. So
Could be.
mortality is anything from 0 to 1%.
Yeah.
That's excellent.
Okay.
Did you publish this paper yet?
We are trying. We are writing.
I can suggest you a good journal.
Okay.
Ophthalmic oncology and pathology.
Oh, the new one. Okay.
Dr. Simpson?
Also, just a comment that it's interesting in the early days of the COMS,
2 or 2.5 eye, sorry? 2 and a half.
So the algorithms changed because people thought that they could detect growth at that level. And so it's interesting, back to the 3, which I think is a very wise thing to do. And it's given us that direction because it's very similar to the thought all along, 0.
Well, we start with this protocol of observation like 20 years ago when Cohn's study had the height in 3 millimeters. And in addition, my experience with the patients is 2.5 and 3 is sometimes are like you have seen small melanomas just in the posterior pole. If you treat the patient, she's going to lose the vision. You have to balance how good is the vision of the other eye. And, well, I prefer to keep observing up to 3 millimeters, and only 9 cases grow.
This is a big series, so I don't think you should worry about the numbers. It's almost as big as the other series, for small melanoma. It's a very big series, and you have very clear data and very clear answer. So it should really be easy to publish relevant.
Okay. Next week.
Thank you, Dr. Sarnil. Your certificate, please. Okay, let's move to the next speaker, and is Dr. João Pessoa de Souza with the topic Conjunctival Tumor in Child Case Report.
Good morning. I would like to say thank you for Dr. Boni to stay here. It's a very pleasure. And I stayed 2 years here in 2003 until 2005 during my fellowship in ocular pathology. So it's come back home like that. So I'm going to present a conjunctival tumor in a young boy. He's a 13 years old, healthy white boy. He had a history, this is in 2013, a 2-month history of spineless pink mass in the right nasal bulbar conjunctiva, which was initially treated with topical corticosteroid without response. The history medical is unmakeable. The examination of the right eye revealed a salmon pink mass with a smooth surface in the nasal bulbar conjunctiva. This is the picture, but you can see here the lesion. This is a salmon patch. So we decided to remove excision biopsy of the conjunctival mass was performed, and a systemic evaluation was made. This is the microscope examination. You can see the diffuse infiltrate of mature lymphocytes involving of the conjunctivus propria, and multiple deep and superficial lymphoid follicles with germinal centers. This is another microscope examination. The histological panel was made, the CD20, the CD3, BCL2, and CD10 was made. This is the Chi sequence 7, this positive in germinal center. So the anti-CD20 B cell marker showed heavy stain of the cells in the diffused fashion, but relative sparing of the germinal center. The moderate anti-CD3 T cell marker immunohistochemistry was seen in the scarred cells of the germinal center of the well-defined follicles and the cells areas of diffuse infiltrate, and the systemic evaluation was made. This is the panel, the final panel. The CD20 was positive in lymphoid follicle. The CD3 was positive. The CD20 was positive in lymphoid. And BCL2 was negative in germinal centers. And CAR-M7 and BCL6 was positive in germinal center. This is in 2016, so after 3 years. And now this boy, after 16 years old, and he now had a new lesion in the other eye. It's a small lesion in the conjunctiva. So I bring this case to decide if I remove or not. But in that time, in 2013, the diagnosis was the benign reactive lymphoid hyperplasia. This lesion is a lymphoproliferation lesions of the ocular annex cover a wide spectrum. It's believed to be a consequence of a chronic inflammation response of lymphoid cells in the conjunctiva, written or antigen stimuli. The benign reactive lymphoid hyperplasia is a fairly common and constitutes approximately 10% of the patients with lymphoid proliferation of the ocular annex. It's not too common, and when I review the literature, it's just on 11 cases in children's. So if it's Jacobiet in 40 patients with conjunctival lymphocyte proliferation, the most common is in older person. So in this presentation, clinicals and appropriation measures are not well established because it's not common to follow these kids. So the association and benign reactive lymphoid hyperplasia with systemic lymphoma has been reported, but it's rare. Low probability of malignant transformation and extraocular extraction. So Copeland report in 112 ocular annex lymphoid proliferation lesions with none of 12 patients if developed localized or systemic lymphoma. Shields report in the 113 adult patients with conjunctival lymphoid tumors, just 1 in 12, 5% developed systemic lymphoma. So some report have suggested more favorable outcome for conjunctival lymphoid lesion compared with the orbit, and recommended reported systemic evaluation every 6 months for 5 years. So in these kids have just 3 years of follow-up now. So the evidence is scarce regarding appropriate treatment of the conjunctival reactive lymphomas. You can do surgery, interferon alpha 2b, radiotherapy, or subconjunctival triamcinolone is the treatment. Thank you.
Do we have any questions or comments? I have a question. Did you treat the patient with steroids before you did the biopsy, or was there a consideration of that?
Yes, as I told you, before he come to me, he was treated with the inflammatory treatment, eye drop.
For how long?
I think 15 days.
And with this lesion on the other eye, are you going to consider treating it with steroids? Given
Yeah,
this biopsy?
I try for 2 weeks, but it's almost the same. It doesn't change anything. So I decided to take a picture and take a look a lot. He come back probably in the next month if there is any difference in the change.
Dr. Singh?
We have probably a similar case of a follicular lymphoma in a child. And so at least our pathologists always ask for flow cytometry. So we always send fresh tissue, and they will do flow cytometry to differentiate and do extra staining and characterization. So was that done?
No, it's not. We don't have this technology in my state. So maybe you can do this in another tissue if we decide to remove then the other another eye.
But we have an identical case that was published. We look at a follicular lymphoma and we see the same appearance, also in the child. So it's difficult to tell clinically, and pathology also is sometimes difficult.
This is the reason I brought this case to here, to hear a little bit more to how to do. But after 3 years, I send the patient for oncology, and nothing. This is the same. Nothing. The tumor don't regrow, and no systemic difference. But you remove the tissue to the other eye?
Yeah, we removed the tissue in one eye, and the other eye, there was a little growth, and then he died and we got rituximab. For each time we give radiation, because we were concerned about toxicity. But he had rituximab for several months, and then it's stabilized.
Okay, thank you.
And again, sometimes it's more than one pathologist has to look at the slide and review before they say it's lymphoma, because it's difficult sometimes to tell almost the answer.
Okay, thank you very much.
Just a brief comment. I'm not a clinician, but maybe a differential diagnosis in the new lesions could be lymphangiectatic vessels, because they are not salmon patch. This is, a comment, but I'm not sure. The experts are here. They know better than me.
It can begin like that, so I think we can observe it. It's not bothering him. It's a low-grade lesion. It may not change at all. It may even go away by itself. So you can just observe it. You're not going to
Okay. Thank you very much.
I would also posit that we certainly as pathology see, even in nevi in young children, an intense inflammatory reaction, and that's just the way I think youth responds to any kind of antigenic stimulation. And because you have a clear reactive process on one side, one might argue even giving them a mast cell stabilizer or some anti-allergy drop with a prolonged course of steroids wouldn't be necessarily harmful other than checking IOP, but I would be highly suspicious that this was anything more than an inflammatory reaction. But trying an antihistamine, or as I said, a mast cell stabilizer may give you some benefit.
Okay, thank you.
The next presentation in the morning is going to be by Dr. Evandro Lucenza, and it's late orbital recurrence of intraocular medulloepithelioma of the ciliary body, a complex approach.
Morning, everyone. My pleasure to be here. I would like to just give me a second, right here. It's a pleasure to be here. It's an honor to be invited to such a great meeting. And the case of today is, right here, is a 3-year-old girl she came to an ophthalmologist with a decreased visual acuity, and a mass was noticed in the ciliary body on a regular exam. So this is the appearance of, this is not properly working. Okay, this is the appearance. You guys can see the mass inside the eye. It's in the ciliary body with an irregular appearance. She underwent UBM, and the UBM showed the irregularity and size of the lesion, which extended from 8 to 11 o'clock meridians with heterogeneous internal reflectivity. Now, she underwent iridocyclectomy, and the pathologist was not able to see the margins of the lesion. Actually, they were not identified, so she had no free margins in the surgery. And she recurred later and has to be enucleated. So this is the case. It was a fantastic case, 3-year-old girl with an intraocular mass, enucleated. The pathology showed she had a ciliary body medulloepithelioma, and in the pathology again, we can see the columnar cells with a round nuclei forming tubular structures like a medulloepithelioma. And in higher magnifications, we can see the rosettes arranged, the cells arranged in a rosette forming. This work was published in 2006, and Michael was the senior author of this paper. And it was a fantastic case. But here's where the interesting part begins, actually, because 10 years later, this same girl has problems in her prosthesis. She was evaluated by an ophthalmologist, and the general ophthalmologist noticed a kind of purptosis, edema in the upper lid, and she went to an MRI, and the MRI showed this lesion right there. You can see the prosthesis on the right eye and a mass molding the prosthesis by the inside part of the prosthesis and the outside of the implant. So it was a very different case. 10 years after the first surgery, she was developing this. T2 weighted showed the lesion in close contact with a Purex implant. So we decided, after discussing the case with the family, she was at this time 13 years old. So we discussed the case with the family. and we decided to make an excisional biopsy, or to remove the tissue itself. So this was the specimen of the surgery. You can see the implant in the lower side of the slide. And the mass, the tumor, is in the upper part of the slide. She had a limited exenteration. We made a lot of frozen sections in the OR. That's why we think it's important to have your ocular pathologist leashed on the operating room. So he's going to be able to see if the margins of the surgery you're doing are perfect or not, if you are free of tumor. This case, the margins were compromised also. So we had to amplify the margins of the lesion. We had to have more tissue to be removed. And guess what? The tumor was a medulloepithelioma 10 years later, recurred in the orbit. So we, as you can see here, again, cells and the aspect of tubular cells with round nuclei and rosettes. So it was a very interesting case. She underwent systemic workup. A few months later, she developed a goiter with thyrotoxicosis in her thyroid. So the pediatric oncologist made a diagnosis of Dicer-1 syndrome, which I've never heard about before this. It was my first case of a Dicer-1 case. So she underwent a pediatric oncology follow-up. And Dicer-1 related disorders is a familial susceptibility syndrome with increased risk for pleuropulmonary blastoma, ovarian sex cord tumors, cystic nephroma, thyroid neoplasia, including multinodular goiter, which is the tumor this girl had, rhabdomyosarcoma, and ciliary body medulloepithelioma. So she had 2 of these tumors, and one with a recurrence 10 years later with a very slow growth. The diagnosis is suspected on the basis of a clinical presentation, imaging exams, and pathology analysis of the biopsied tissue. She is under investigation with a MLPA analysis for a mutation on Dicer-1 gene. Dicer-1 is an enzyme. When you have these mutations on these enzymes, the enzyme doesn't work, and the enzyme is important to epigenetic control of gene expressions of a lot of tumors and responses to viral infections and so on. So it's an important enzyme, which I've never heard about these Dicer-1 disorders before. The thing is, this girl underwent later as an adjuvant therapy, a stereotaxic radiation therapy. She received 36 grays of stereotaxic radiation therapy in 20 fractions, daily fractions. And 5 years later, she was reconstructed at the same time of the surgery. And 5 years later, she had an excellent result. We have now 5 years of follow-up of the second surgery. So that makes 15 years after the first and after the enucleation. And now she is a gorgeous girl, a 19-year-old gorgeous girl. She sent the photography so we can show her around here. And one thing that I learned is there's always a patient in the end of the day. Thank you very much for your attention.
Thank you. Are there any questions?
A little bit about the Dicer syndrome. So a few years ago, there are a group of people who maintain a registry on pleuropulmonary blastoma. And they, in their registry data, which is a rare disease itself, they identified 3 or 4 cases that are medullary. And they put together a paper and submitted to BJO. And I was the editor at the time of BJO, and we published that. That was the first thing. Again, coming back to the registry data, rare things, mesothelioma. So it's the registry, and they identified that some cases of mesothelioma have this kind of sense of fact.
The NCI, National Cancer Institute, is doing this, right? It's on clinical.
Yeah, so I mean,
Clinical.
how it is, but this is almost 6-7 years ago.
Uh-huh.
The first paper came out in PJO
Right.
from the registry of
Right.
rural
Right. I heard about it.
It's kind of interesting.
Thank you for your comments. Any comments? Thank you very much.
Okay, let's move to the next speaker. Is Dr. Rubens Belfort Jr. and with the topic ocular involvement in Zika virus infection.
Thank you very much. It's a great honor to be here again. And Miguel and I are brothers, but I want also to be more formal now and express the official position of my university regarding all these years that Miguel has worked with us and has been very important for my institution to achieve goals in education as well as in research. Miguel, this is a special hi from everybody there. Miguel has been working there since in the 80s, has finished over 50 PhD theses, students from many places of Brazil and Latin America. We're very proud and happy having you there. I want to express our gratitude to you and Noralia. I'd like to discuss with you today some information regarding Zika. Dr. Vasco Bravo Filho yesterday described it very well. Some of the ocular findings associated to Zika. We've been working with them in Recife since November last year, and what is amazing about this is that everything started 6 months ago. There is almost nothing before that, and it's a puzzle, and of course, very difficult medical situation, but for research, it's fantastic. Very, very exciting field, a lot of information coming, and one of the few areas in medicine now that really has been put in higher priority, not only for Brazil, but for many countries, as you know. It's everywhere. Sex transmission, maybe the possibility of a husband with asymptomatic viral disease could transmit to his wife and lead to these very severe neurological diseases. Also, a possibility that people should avoid pregnancy at the higher risk regions. And we already have people moving from one country to the other to avoid the risk of the infection, and no doubt it's changing the behavior of many people and very, very strong economic impact also. These are some of the headlines, CNN, CDC, WHO, and everything is concerned. Why? Why should they be concerned? Well, we should be concerned because it's a severe disease and also because still there is no science behind it. And we know that only good scientific work can bring results and improvement. And until we have treatment and vaccine, the only thing we can do is to kill the mosquitoes. Different from HIV, different from other disease that is behavior related, this is not the case with Zika. It does not depend on us, it depends on the mosquito. The mosquito has changed a lot. It went from the forest to the cities. Now it can reproduce much quicker and the place there was never supposed they would be. So the mosquito right now is the only way we can control the disease. Treating a pregnant woman with this viral infection would be very complicated and difficult. Can you imagine to approve a drug that would be given to pregnant women, apparently healthy. This drug would have to cross the barrier, the placenta barrier, get to the fetus, destroy the virus without causing any neurological problem. You can imagine the clinical trials, all the work that would be needed for that. Vaccines are very far away, and even the optimistic people say at least 4 to 5 years, $2 billion. Well, we have the Zika virus, we have the Aedes aegypti, and we have also the patients. And the patients are increasing in number in many, many countries. Very complicated to deal with this situation. How can we rehabilitate a child like that? There is no eye, there is no ears, and no brain. So most of the cases, you're going to have to deal with this for 50, 60 years. Very often, the marriage breaks the first 2 years after the diagnosis, and very often also the mother and the parent abandon the child. So we have now almost 100 abandoned children in Brazil because of that. Very complicated to examine these children. Technology exists, but it's very expensive. You probably do not know by heart or the cost of one of these retina cameras. $90,000, $100,000. So 10 cameras would already be $1 million. We would need, I don't know, 50 to start with in Brazil, and maintenance of that. The northeast of Brazil, there is probably 1 or 2 available cameras. We have to bring our cameras from São Paulo to the northeast to take pictures, with exception of the unit in Recife. There are no other units available. So very complicated. We know there is a technology that could be used, but it hasn't yet been developed. The only way to increase the diagnosis would be to adapt the technology and take pictures with iPhones and similar smartphones, because with the system that is available is just useless for most of the situation. This is one of the units we're working in Bahia. They have a nice intensive care unit for infants and newborn children, but it's the only one in the city. And as I said, we have to bring this camera from our university to there 2 hours by plane. We know that the virus, besides causing cerebral problems, can also give other birth defects, as this child that died 1 day after I took the picture. And in this intensive care unit, at the time we were there in December, we had 15 children like that. And this is one of the lesions that we see. Of course, could be other disease, but it's not. All these children have been ruled out for all the other known infectious diseases, and they are different, but they have the same pattern. So usually they tend to be bilateral, they tend to involve the posterior pole of the eye. You can have only retinal lesions or optic nerve problems, but usually you have retina and optic nerve. Very important questions to address is, first, is it possible that, like toxoplasmosis and rubella, children born apparently normal and develop neurologic and ocular lesions later in life? Yes, it's possible. Is it possible that the disease would affect not only children with microcephaly, but also children with a normal cephalic perimeter? Yes. And this would, of course, increase very much the number of children to be assessed and the number of children with the disease. Is it possible that sex transmission and saliva transmission plays a role? Yes. Is it possible that even infections before the pregnancy could lead to congenital defect? Yes. And that's very important. We know that in the past, many situations now we know are infections were considered non-infections. We have followed these children now. We have hundreds of children already under this cohort, and we're looking for other birth defects that may be caused by this virus. So we don't know, maybe microcornia. Some of the microcornia could be caused by viral infections during pregnancy that until now had never been suspected. So as in HIV and AIDS, medicine will advance a lot with all the suffering of these patients. Is there an environmental factor? Maybe, because we know that some parts in Brazil, the disease is much worse than the others. Does yellow fever vaccination play a role? We don't know. Is it possible that yellow fever vaccination protects somehow and would explain the reason that in south of Brazil had much less? We don't know. So there are many, many, many unknowns. We already know that it's not necessary for the mother to develop red eye to be at risk. Most of the mothers have even normal pregnancy and they do not refer any symptoms related to Zika. We have a paper coming at the JAMA May 26, and explore these risk factors related to the ocular lesions. All these patients had been excluded of other infectious disease. And this has been also a nightmare in many countries because, unfortunately, even syphilis is not in 100% of the cases ruled out in Brazil. So many, many, many of the cases are syphilis, are toxoplasmosis, are rubella. So very important to exclude them and all the difficulties of doing it in countries and regions without a good public health system. We would have to see and examine every child born with Zika or at risk for death. And as I said, the red cam and the technology available is just impossible to be afforded by most of the countries. Also, PCR is good only in the acute phase of the disease, few days. So a pregnant woman gets Zika in the first trimester. At the time the child is born, no PCR would help. Very few exceptions. So we have to rely on serology. Thanks God, serology now is available. It was not available until 2 months ago. We still debate a little bit about how specific it is. Probably it was not as specific at the time we're using immunofluorescence, but now with ELISA it's more specific. But still not 100% sure. Most of the patients, we have to go for the CSF and look for IgM antibodies in the newborn. So on top of everything, you also have to have money and personnel to do these exams in these small children in order to get the IgM positive on them. And this is the criterion that we use in the paper that's coming out. Right, explore that. So we started seeing these patients in end of November, first week of December, and for us it was obvious that was something new, and I think we were right. At least they accepted the papers, and this is roughly the situation in Brazil. The mosquito is everywhere. Mosquito is in Rio. Mosquito is in the state of São Paulo. Mosquito is everywhere, but the Northeast has much, much more than other races. Why? We don't know. An important outbreak focus is now Ribeirão Preto, a city in state of São Paulo, close to Mato Grosso and Paraguay, and we suspect there is much more of this disease in regions, at that region that has been noted. The Brazilian government, with the help of NIH and international agencies, is starting a cohort with many hundreds of pregnant infected women, and we're going to follow them, we're going to follow the children to see exactly what is the role of this infection. As you see, it's everywhere. And why is that so important? Well, this is mosquito. Miguel, only black and white Corinthians-like mosquito could be so bad. And Aedes aegypti, it's okay, but worse than Aedes aegypti for many is this one. Why? Because this one is in the United States. It's everywhere, almost everywhere in the United States. And that is the big risk, because so far the disease has been transmitted only by that, but there is some evidence that this may also be starting to play a role. And you see here the distribution of Aedes aegypti below and the other one above. You see the United States is at high risk, as well as many, many other countries. And of course, air travel. The world is linked, and you get the infection in Brazil. The next morning you are in New York, and 2 days later you are in Ilha de Madeira, and then you can go to Eastern Russia, and Ilha de Madeira and Eastern Russia are the two places announced by the WHO as having now a very high risk of getting the disease. Emmett Cunningham has helped me to put these slides, and so I want to give credit to him. But you see, it's the same family. Yellow fever, West Nile, dengue, Zika, they're the same family, the same type of viral. And West Nile virus is other disease that have very, very, very attention, because officially it did not exist in South America, but it's been diagnosed in Argentina, and it's probably also in Brazil. We all have seen cases like that you just say unknown, or we call some fancy names such as white dot syndrome and things like that. So this all may be viral. This all may be infections that are going on even without being noticed. You see here, dengue is another example. Dengue in Brazil is a big, big problem. And you see, if you don't look for this, if you don't suspect, if you don't ask the test, you're going to miss it, and you're going to cause, I don't know, inspecific vasculitis, ocular beachhead, and so on. Another examples, other countries, we have this also in Brazil. Dengue, chikungunya is another viral related to that. Chikungunya, again, this is 2013 book, completely wrong, because that's the real situation. Chikungunya is another outbreak, and the rheumatologists are in panic in many places because of that. Chikungunya means walk bent over, causes a lot of problems, including ocular lesions. And you see here some examples. Again, if you don't suspect for that, if you don't look for this etiology, you're going to miss it. There are many, many fancy names that we could call this disease. If we do not know it caused to the virus. This is Zika. Zika comes from this forest in the Africa, and then this is the situation that what the strain we have in Brazil did not come from Africa. It came from the Pacific, came from Micronesia, and probably was present in many places at a very low rate, and we don't know the reasons. It exploded in the last 2 years. This is the first paper that was published in Japan, trying to correlating the red eye with Zika, and that's the reason that until December, people were saying that women, a pregnant woman, would be a high risk if they develop red eye. It does not apply to Brazil, as I said. The pregnant women do not refer red eye. That situation where Zika could spread, including the whole Central America, South America, and a good part of the United States, and that's the reason that everybody's concerned. You see, microcephaly. Okay, I have no time to go over this, so let's go. These are some of the examples of the severe macular neuroretinal atrophy. We never saw inflammatory cells. No inflammatory cells in the vitreous, no inflammation in the anterior chamber of the eye, and high risk of lesions. This is a paper that was published in Brazilian Archive of Ophthalmology. Actually, this was the first paper correlating the ocular lesions and Zika. Could be, of course, other infections. That's the reason we have to exclude them. And this is the patients now from Salvador. and other aspects of it. No inflammation. We believe that there's no inflammation. This is just because the normal tissue is not formed because the influence of the viral on the genes that would lead to the normal development. So going back to the situation, I see no possibility of rehabilitation. There is no treatment in the horizon, no vaccine, and controlling the mosquito is the only thing that can be done so far. Is the subject that I am sure will continue to be investigated and unfortunately present in a higher number of countries. I want to thank you very much, again, the opportunity of being here. I'm not a pathologist, I'm not an oncologist, but having a son in oncology and a brother in pathology, I feel part of this family. Thank you very much.
Any question or comment to Dr. Belfort?
I think when you show that slide saying lessons to be learned, reminds me of our story about toxo, because that's how we started. A lot of things in toxoplasmosis at the time we described the acquired disease, and Rubens was the one who did it. The things that have been published and things that we believe were completely wrong. Then my concern with this is, for example, is IgM, in your opinion, positive for how long? We probably don't know yet. And number two, as you described so well, what are really happening in different regions of the world? Number three, lack of inflammation. Are mothers and children a sort of immunodepressed, or is there any, or the virus does not impress the immune? It's incredible how there's no inflammatory cells at all, zero. Inflammation doesn't exist with a lesion of that size. Look at this. Then I think there's much more things that we don't know, and we're going to have to learn. The problem is how to do systematic approach to something that is in epidemic proportions. Then there's the urgency in one side, and there is what will have to be done in other side. And usually we do things in an urgent way because we don't do the important things. Then it's going to be very difficult to solve this. Do you believe the cases are now on a plateau, or they are progressively getting worse, meaning in terms of numbers?
It's spreading out. We have a case from the city of São Paulo. The mother and the father never left the state, and the child was a typical case. So we know that the disease is already in the state of São Paulo. In Ceará, there is over 100 patients like that. There are many of these patients in Rio de Janeiro. But what I think it's bad, I'm ashamed of, is that there is still no ocular pathology study. Many of these children have died, and we've been trying to get the eyes since December, and very complicated situation, lack of good infrastructure over there. I cannot move to there and go by myself. We try very hard, people from Recife, people from Bahia, are trying to get eyes to be studied, because it's never been studied, Miguel. The few reports studied the brain, studied other parts of the body, but they missed the opportunity of studying the eye. It's a shame. Shame. So any of you that could have access to one of these eyes should really do a good study and try to get international cooperation. Miguel is involved in that. Miguel is part of our study. We have been doing some viral tests with the University of Texas. People from New Haven is also very instrumental on that. And so far, no ocular specimens. It's a shame. We need to get this optic nerve in the eyes and go ahead and do everything we can in order to advance, right?
Dr. Belfort?
Yes.
Just a quick question. Is it 100% in women who are in the first trimester who get a Zika rash that actually have children born with microcephaly, or are there normal children born when there's been what looks like documented infection?
There are many children that are born normal from a pregnant woman carrying the virus, yes. Probably a small number of these children are born with the disease. We don't know if some of these normal children would later on in life present cognitive, psychological, psychiatric, neurologic, or visual problems, because we know this happens in other infectious diseases. So this is part of the puzzle, part of the nightmare. We have to follow the students, see what's going to happen in a few years. And we know also that most of the children, most of the pregnant women develop the children with birth defect if they get the disease in the first trimester of the pregnancy. But we don't know about the other. Maybe exactly like toxo. You see, the children infected last part of the pregnancy are the ones that are born apparently normal and later on develop macular, ocular, blah, blah, blah lesions.
Our next presentation will be Flavio Rezende on Argus 2.
Thank you very much. I never had the pleasure, the opportunity of following Dr. Belfort. When you reach a certain level in your career, I guess it's no longer about the amount of publication or the kind of publications. It's about the amount of seeds that you planted worldwide, and that's one impressive thing that Dr. Bernier is able to provide us. It has planted amazing seeds around the world. I'll try to keep it short. It's totally shifting gears here in terms of ocular pathology. So they asked me to speak about our experience with the retinal chip implant. Yes, please, next. Can I advance here? Yes, thank you. So this is the implant that we place, the current widely available implant that we've been having the experience with. And so these are a technology that is devoted to patients with outer retinal degeneration. The hallmark disease would be retinitis pigmentosa. So it's a little modified glasses that has a camera in the middle, in the center of it, and it's connected to through a cable. It's connected to a pocket-sized computer where the information from the camera is processed, and it gets back to the glasses and wirelessly sends the information to the piece in the eye.
Here with Mr. Dwayne Tsutsui from Second Sight.
It's a little explanation of how the technology works. This is one of the guys.
It all starts off with the
it's
implant.
A company out of California
implant
named Second
consists
Sight.
of
No
a
financial
set of
interest.
electronics that is actually attached to the outside of the eye with a cable that's inserted into the eye, and it's attached to the retina. The glasses contain the camera that actually captures the scene. So whatever the camera captures, the image is sent down to our video processing unit that the patient wears on their belt.
The VPU then converts these video images into electrical signals and sends them back to the glasses. The coil on the glasses sends the signals wirelessly to the implant. The implant then sends out small pulses of electricity to the retina. These pulses stimulate the retina, and the resulting signals travel along the optic nerve to the brain, where they are perceived as patterns of light. Over time, users learn how to interpret these visual patterns as objects and shapes.
This is a simulator, Lana, that it gives the closest representation to what a patient would actually see. It's only black and white, it's not color, and it's somewhat pixelated, a little bit blurry, because it does not give perfect sight. It allows you to see shapes, contrast, So if you look at things such as this black square on a white background, you should be able to see that fairly clearly.
Like Geordie LaForge's visor, the Argus 2 has proved it is possible to provide an artificial form of vision. During the use of this system, some patients were able to locate lights and windows, follow lines in a crosswalk, and avoid running into things as they were walking. Some patients were even able to sort laundry or determine where other people were located in a room, and some reported seeing lights and motion after being blind for many years.
Patients have even been able to see large letters.
Ah, it's a T!
Yeah, so
Wow.
it doesn't give perfect vision, but it does give enough to where they can identify objects and see things. And
So obviously, this is a very low definition, but we're talking about patients that are completely in the dark. So that's the goal of the technology is to bypass the photoreceptors and stimulate directly the retinal ganglion cells. So who are candidates for that? So adult 25 years or older with severe to profound outer retinal degeneration with LP to bare LP or no light perception. Previous vision in the past is important to have that memory of having had vision in the past. Limitation in axial length because there's a cable that connects the outside piece of the eye to the inside, and no other ocular comorbidity. So we had the opportunity of being the second center in Canada of doing the implant last year, and this is the patient. It's many things that we have learned to operate these severely affected retina is that the posterior hyaloid is super attached to the surface of the retina, and obviously we can't have detachment during the case to allow us to proceed with the implant. So very briefly, this is a surgery. It's for those who are more familiar with retinal surgery. It's kind of like a combined buccal and vitrectomy surgery. We have to loop the muscles and place a band that is attached to the external part of the implant. And so we slide it under the muscles. We put it pretty much the same way as we place a buccal, except there's a huge piece attached to it. And so depending on each eye, so this is customized to exactly the size of the eye, the axial length, where we place the sutures. It's a super delicate structure, so like the metal of the needle can't touch the array, the electrodes, the cable. It's very, very delicate, so they developed this specific forceps and it's the only thing that we can manipulate the piece with, and it's hard because it's compared to an eye, it's a pretty big piece to manipulate. So the 3 points of fixation, it's important not to allow the implant to move around or to expose. One of the main complications is conjunctival erosion because of the size of the outside part of the implant. So then we perform a 4-port 25 gauge vitrectomy because we need a chandelier light for the placement of the implant over the macula. So during the vitrectomy, we 100% of the time we need to stay with triamcinolone because what I mentioned, the posterior hyaloid is super adherent. And one thing that we have been learning with our experience with the endoscopic vitrectomy is that most of the time when the posterior hyaloid is attached, the anterior hyaloid is attached as well. And you don't want to put inside the eye an implant that is it requires a 5.5 millimeters incision of ars plana if you're dragging vitreous in the wound. So the addition of the endoscopic vitrectomy, in our point of view, is crucial. So as you can see there, that seems to have a dense anterior hyaloid that it's exactly the area where we have to place the sclerotomy. Again, 5.5 millimeters incision. For those who practice vitreoretinal surgery here, understand how big this is to put inside the eye. So we pre-place the suture where the cable will be. So what we did, we placed, before doing the incision, we placed a 26 gauge needle, and as you can see how only a 26 gauge needle is dragging the anterior hyaloid. So in patients that have a pretty adherent posterior hyaloid, you should expect to have as well a pretty adherent anterior hyaloid. And one may want to approach this with a very low rough vitrectomy at the anterior vitreous space region. So because we had the opportunity of having the endoscope, so then we went ahead and we detached the anterior hyaloid and removed that before making it. So you see just the anterior hyaloid just snapping. It behaves a little bit different than the posterior hyaloid. And this way, so we enlarged one other thing that it's related to the presence of the cable. So keep in mind this cable connects the outside part to the inside, so it will always be there. So it's crucial to have a very perpendicular wound to the scleral plane. Otherwise, the cable tilts the chip inside the eye. So then we slowly enlarged the wound with different blade size. So this is MVR, like around 20 gauge blade. Then we enlarged to a 275 incision. And as you can see, that's maybe one of the first times that we were able to see that. As soon as we remove the blade, the wound actually contracts and decreases in size. So that's why sometimes we have a hard time. Well, I thought I did the correct measurement. It has the ability of contracting a little bit. So now, like enlarging more, and then you can see the residual canalog crystals floating all over the place because of the size, the large size of the wound. And so then there's a holder where the only place in the electrodes that we can actually hold the chip to place inside the eye. Again, with a 25 gauge infusion line in a large wound like that, it's a period that you shouldn't take too long to try to avoid the extended period of ocular hypotony, intraoperative hypotony. So that's like an endoscopic view of the implant being placed inside the eye, and as soon as you get out, you see the amount of fluid that floats, and it actually may even make the chip, fly in different directions. So with the specialized forceps, you try to just to put the cable inside. Very tough and very crucial part of the surgery is to try to seal that wound with a cable, 2 millimeters wide cable plate being there. And so then we're ready to place the tack. So the tack, it's actually a nail that goes through the retina, the choroid, and actually it's fixated on the sclera. It's obviously a procedure that we're not used to do it, so you actually really have to squeeze in to allow it the harpoon-like tack to fixate the implant. Many of these patients have nystagmus, so it's very important to have the chip well fixated. And so this is a specialized forceps for the case. So then you see the entry of the cable pretty flat, straight, and to allow a good contact, because the least amount of contact that the implant has with the retinal surface, the least connections with the ganglion cells. And this is the first week post-op showing the ideal positioning of the electrode array, and in very good opposition to the retinal surface. For those who are Brazilians, one of our main networks in Brazil came to film the performance of our first patient. This was the first day where her camera was turned on. If you had the audio with you could see that she was absolutely completely blind, and when the first time that she had her camera on, she was already able to detect the white square on a black background. And most importantly, when this lady, she actually married her husband, she met her husband while she was already blind. So this was the first time that she actually saw the silhouette of her husband 9 years later. That's one of my concerns. I'd like to thank our team that was involved with the surgery. Many people, Turan, which was one of the former retinal fellows here at McGill, came to help us with the surgery. But what's next? So because of all the media exposure that we had here, if you look critically, that's what the surgery looks like in the outside. So we got to do better than that. You saw a simulation of what the patient can actually see. That's not really a 2016 type of image quality. So because of the media exposure that we had, we were contacted by the Department of Physics from University of Melbourne, which is the same people that made the cochlear implant, which is a very successful story in medicine for the deaf people. Went there to lecture at the Bionic Institute at Melbourne. The group came to Canada. They founded a startup company, Canadian startup company, and we are fortunately going to be involved. We are actually designing the surgical technique for this next generation implant. This is going to be done all here in Montreal. So one of the main advantages of this technique is that actually there's nothing outside the eye. So all the implant, the chip technology, everything, it's inside the eye. It's going to be epiretinal, so there's no outside surgery to be done. So many of the complications that we currently have, we may be able to avoid. And the chip will be stimulated by a laser type of glasses, a little bit like the Google Glass that you guys may have seen. This may allow us for multiple software updates, and anyways, there's a lot to do. This was the first Argus that Argus 1, this was the definition that patients had. The Argus 2, which is the one that we implanted here, that's the definition that they have, and that's what we're aiming for, and that's the actual image. So there's a lot of work to be done, but I believe that we're starting to be on the right track of helping these blind patients that otherwise don't have anything to be done. Thank you, Professor.
Any question or comment to the doctor? Dr. Rubens-Wilford.
Congratulations, good work, as expected. What is the situation in Canada regarding reimbursement?
Yeah. So
that's one of the big problems, very, very expensive. It's good for Saudi Arabia, but in Latin America.
Yeah, exactly. So the first center in Canada was in Toronto, and when they started, Health Canada hadn't approved yet, so they had a $1 million grant, and that's how they did their first 5 or 6 patients. We were fortunate to have our hospital foundation to fund the first implant, but this was already after Health Canada approved. So we're just finalizing now, beginning of June, a big dossier from our hospital in conjunction with a visual rehab place, because there's a lot of time that have to be spent on visual rehab for this kind of vision. And we're sending to our government here in Quebec for possible reimbursement as these type of technology has been approved here in Canada.
Is it true that the general cost first 2 years would be above $200,000 altogether?
Only the implant is $150 US.
150.
150 US. Yes, that's only the implant. So 1,000 US. So that's not counting the surgical team, everything else, like the rehab, everything else. It's outside this budget. And well, this new technology that we're working on, that's actually one of our main focus, is to try to cut down the cost as the technology improves. It's just like our TVs, right? So this, what I see, this is like a black and white TV that costs a lot of money, and then now, but it's in an era where we have 4K technology. You know, so we will be able to move much faster. And what I like about this technology is that it's a little bit different than the genetics and the stem cells that people have been working with this for years or maybe decades, and now they're having a glimpse of perhaps preserving visual field. This is something that would be bypassing the photoreceptors, and we're learning more and more how to connect a digital image to the ganglion cells. And now with this newer OCT technology, we're actually able to measure the density of the ganglion cell complex, and this may allow us even to recruit better patients to have better performances. There was one guy from one patient that had an implant from the Netherlands, and he was able to learn how to ski and to shoot arc et flèche, arrow, bow and arrow, I don't know how to say it, after doing this. So for some people, usually the younger patients who are more adapted to the newer technologies, they profit more from this type of technology. And another thing that we want to address is to, as you improve the technology, we decrease the chance of the patient failing using their digital device. Thank you very much. Oh, sorry.
One quick question.
Yes.
When Mark and I started looking at this maybe 15 years ago or so, there was big discussion there that something was comparable with the cochlear implant, the history of that, in that there comes an optimal point at which the reception can be placed, and the brain will be plastic enough to fill in the details. Have you arrived at that kind of optimal point in terms of what you're aiming for?
Yeah. We've been juggling between, so the current organs implant has 60 electrodes. What we're working on, it's ranging between 256 to 1,000. And we don't really know if the 1,000 is better than the 256. We don't know yet, yeah. Because the electrodes, depending on the size of the electrodes, we're able to get a bigger amount of ganglion cells nearby. So if you increase the density of the electrodes, they become smaller, so they have a less of a catching area, if you will. So we're juggling with this right now. We're trying to determine which one would be.
Which were the major complications that you had?
Yeah. So the first, like, to have this technology approved, obviously was better for blind patients. Okay. So right now the approval is for bare light perception to no light perception. There's a current ongoing study in England that are addressing a geographic atrophy in AMD. So there has been already 5 patients being implanted in a phase 1 trial in England. So and now that's another question, is that now we're also starting to learn how a digital image is mingles with a peripheral physiological vision. Because we didn't know this before, because we were only implanting on blind patients. And now we have to understand how can the brain, the plasticity of the brain, how can we figure out the digital and the peripheral field of vision. Yeah, so the complication, because on this technology, because you have a cable that goes inside the eye, hypotenuse is a major one, and conjunctival erosion, another one, and everything that can come through from this retinal detachment, choroidal detachment, and endophthalmitis. Very low to the size of it. It's pretty low, the complications, the reported complication anyway. But it's something that I would like to address this as the technology advances. Thank you.
Thank you very much. The final presentation of the session is from Christina Miyamoto, and it's cilioretinal artery occlusion.
Good morning. It's an honor and a pleasure to be here meeting friends and participating in such a great and special event. I'd like to thank and congratulate the organizing committee, especially Tiffany, Kathleen, and Dr. Burnier. My first time at the lab was in 2006 when I did a 3-month observership, and it was such an enlightening experience, and I loved it so much that the following 3 years I came back during my vacation time from the ophthalmology residence, and when I finished, I came back in 2010 to do my PhD. So this case is not very common, but it has an interesting finding, and I thought it would be nice to share with you. I'd like to acknowledge Dr. João Rafael Dias, a 28-year-old female presented with a 1-month history of reduced vision in the left eye. She denied pain and any other ocular symptoms. Her social history was remarkable for cigarette smoking for 15 years. Her past ocular, medical, and familial history were unremarkable. On examination, her best corrected visual acuity was 20/25 in the right eye and count fingers in the left eye. The anterior segment and intraocular pressure were normal in both eyes, and gonioscopy showed an open angle bilaterally. The fundoscopy of the right eye was normal, and the left eye showed the presence of a cilioretinal artery and opacification of the macula that can barely be visualized in this picture. The fluorescein angiogram of the right eye was normal, and in the left eye, we could see a delayed filling of the inferior branch of the cilioretinal artery, as well as some hypofluorescent areas in the macula on the late phases of the exam. The spectral domain OCT, on-face OCT, and OCT angiography of the right eye were normal. And on the left eye, on the spectral domain OCT, we could see a hyperreflective band at the level of the inner nuclear layer, which characterizes paracute, paracentral acute middle maculopathy. On OCT angiography, we could see attenuation of the deep capillaries of the retina, and on face OCT, we could see a hyperreflective band on the macular ridge. Systemic workup were negative for, was normal. And when we asked it again, the patient, about her social history, she revealed that the use of cocaine sporadically. So we had a cilioretinal artery occlusion combined with a paracentral acute middle maculopathy. Cilioretinal arteries can be present in about 30% of the eyes, and in approximately 19%, they can be responsible or contribute to the macular blood supply. Cilioretinal artery occlusion represents 5% of retinal artery occlusions. They can be isolated or associated with central retinal vein occlusion and anterior ischemic optic neuropathy. Paracentral acute middle maculopathy was described by David Saraf and co-workers in 2013 as a presumed variant of acute macular neuroretinopathy. It's characterized by band or plaque-like hyperreflective lesions on spectral domain OCT at the level of the inner nuclear layer. It's usually associated with vascular disease, mainly the retinal ones, like, non-proliferative diabetic retinopathy, retinal vein and arterial occlusion, and retinal vascularis. It can also be idiopathic or associated with extrinsic factors or conditions such as migraine, use of some medications, and even viral infection. There can be permanent scotomas due to permanent thinning of the inner nuclear layer. Currently, there is no treatment for this condition. The management is started to identify and treat vasculopathies or risk factors when present. I'd like to thank Professor Bernier, Nora, all my lab friends for helping me make some of my dreams come true and making my life here so happy. And thank you all for your attention.
Any questions or comments?
Does anybody have comment on the OCT? Priscilla, do you think if OCT is pathognomonic or helps?
Regarding the paracute, yes, the finding of the hyperreflective band in the inner nuclear layer is pathognomonic. And about the OCT angiography, the attenuation of the deep capillaries, retinal capillaries is also not finding usually seen.
The use of cocaine has been reported in all the cases, right?
No, the use of cocaine, there is, I could only find a paper that they have the association of ciliary arterial occlusion. Usually, like the use of cocaine can be associated with occlusions of the retinal vessels, and there is only a paper with both findings, the ciliary artery retinal occlusion and the paracentral acute middle maculopathy.
A quick question and a point. Was this temporally related to an episode of cocaine use? Like had she just done it the night before, or did it occur within a confined period of time?
We believe so. Like the use of cocaine probably contributes to the occlusion of the ciliary arterial retinal because the systemic workup were negative, and but the paracentral acute middle maculopathy can be associated with the occlusion of the retinal vessels. So the main reason could be the use of the cocaine in this case.
Thank you very much. I'd like to thank all the speakers, and this concludes the morning session.